Good day, everyone. I'm Pooja Joshi, your host for today's episode. In this session, we focus on a condition that is common yet often misunderstood: irritable bowel syndrome, or IBS. To help us navigate this important topic, we are joined by Dr. S. Agarwal, gastroenterologist, Mata Chanan Devi Aspatal, Nai Delhi, a respected expert in functional gastrointestinal disorders. Today, Doctor will walk us through early symptom recognition, simplified diagnostic approaches, and effective, evidence-based management strategies for IBS in routine clinical practice. Doctor, thank you for being with us. Let's begin our discussion.
Hello, I am Dr. Sriram Agarwal, consultant gastroenterologist at Mata Chanan Devi Hospital, New Delhi.
So, doctor, question for you is, what exactly is IBS and how would you describe it in simple terms to a non-specialist?
IBS is a disorder of gut-brain interaction where there is no visible damage to the digestive tract. Rather, it is a functional issue with problems in how the gut and brain communicate, making the intestines more sensitive and affect muscle contractions and bowel mobility, and it can be aggravated by many factors like food, infections, stress, and emotions.
In your experience, how does a typical IBS patient present in an OPD?
Commonly, the patients with IBS presents with symptoms of abdominal discomfort and pain associated with alteration in their bowel habits. Either they go for the stool more frequently or less frequently, or the consistency of the stool becomes too hard or too soft. And commonly, also they complain of a feeling of incomplete evacuation, and abdominal bloating is again a common symptom in patients with IBS.
How important is the patient's history compared to investigations in IBS diagnosis?
History is the most important aspect in making a positive diagnosis of IBS. Investigations are recommended only in patients who have some alarm features or some atypical features. Otherwise, in majority of the patients, by careful history taking and by excluding the presence of alarm symptoms, we can make a positive diagnosis of IBS.
What are some common mistakes in diagnosing IBS at the primary care level?
The most common mistake is ordering extensive investigations for making a diagnosis of IBS, which for majority of the patients are not required. If we take proper history of the symptoms and if the symptoms fit in with the diagnosis of IBS, then we need to exclude any alarm symptoms which may point towards any organic disease. And once that is ruled out, we can make a positive diagnosis. And this is the most important mistake I consider people make in making a diagnosis.
Are there any warning signs where a physician should immediately refer to a gastroenterologist?
Yes. In making a diagnosis of IBS, we have to exclude all the alarm signs which indicate towards an underlying organic disease. And these alarm signs include unintentional weight loss, fever, blood in the stools, nocturnal diarrhea, if there is anemia, or if there is a family history of colon cancer or celiac disease or inflammatory bowel disease. These patients should be referred to gastroenterologists for investigation.
Once IBS is diagnosed, what is your first-line approach to management?
The first-line approach in management of IBS is to make a positive diagnosis. By making a positive diagnosis, we allay the anxiety of the patient about serious nature of the illness and establish a positive rapport, which is the most important step in the management of these patients. Because once the patient's confidence is gained and his apprehensions of anything serious is ruled out, half the battle is won.
How important is patient counseling in IBS management? What key messages do you give?
Patient counseling is the cornerstone in management of IBS. Once this step is done meticulously, the success of treatment is ensured. The key components in patient counseling are educating the patient about pathophysiology of the symptoms, benign nature of the disease, accepting their symptoms as a change in bowel habits rather than being anxious about the symptoms, and simple lifestyle interventions to reduce those symptoms will help these patients.
What are some practical ways physicians can build patient trust in IBS treatment?
The first and foremost is listening to the patient's symptoms attentively. Try to understand his concerns. Be empathetic. Do not brush off his symptoms as psychological or functional. Make a positive diagnosis of IBS. Do not over investigate. And even when you need to order some investigation, we must explain that these investigations are to exclude certain illnesses which can present with similar symptoms rather than that we are suspecting something serious. That is why we are ordering these investigations.
What advice do you give to patients for long-term gut health and relapse prevention?
The first and foremost is the healthy diet, which means avoiding unhygienic food and processed foods, taking a high fiber diet, adequate water intake, and this should be combined with physical activity, good sleep practices, and stress management.
What's your message to young doctors who hesitate to label a case as IBS?
Do not hesitate in making a positive diagnosis of IBS because of the fear of missing out an organic disease. By following the Rome criteria, carefully analyzing the patient's symptoms, if they are compatible with a positive diagnosis of IBS, then we should rule out alarm features carefully. And once patient does not have any alarm features, we can make a positive diagnosis, and we must order tests only to rule out certain alternative diagnosis if a strong suspicion is there. Thank you. Thank you for patient listening.
Thank you, doctor, for sharing such valuable insights on IBS. Your clarity and practical guidance will certainly help both physicians and patients approach this condition with more confidence. To our listeners, thank you for joining us. Stay tuned for more expert-led conversations. Until then, take care and prioritize your gut health.